Hi, my name is Ann Morrison, and I am an optometrist and clinical assistant professor at The Ohio State University College of Optometry. My position at Ohio State allows me the opportunity to see patients in clinic, teach, and perform clinical research. My research interests vary widely, but my main focus is in infant vision development. Most babies, if born with no major complications or serious systemic health issues, should be farsighted at birth. But then, during the first year or so of life, they should rapidly lose that farsightedness to where they hopefully have little to no prescription entering early childhood, which typically sets them up for the best visual success. This normal process is called emmetropization. For whatever reason, about 7 to 10% of babies are born with a higher than average amount of farsightedness that puts them at risk for not undergoing that normal emmetropization process. When this happens, those babies end up maintaining a higher prescription into early childhood, and that is when we start to see a lot of problems pop up. Those babies are at much greater risk for developing conditions like lazy eye, which is also known as amblyopia, or developing an eye turn, which is also known as strabismus. These can cause permanent vision loss if not detected soon enough, and a lot of times these conditions are not caught until children are much older, when it can be very difficult to get them corrected to 20/20. They then can have issues with depth perception, and they can also suffer a lot of other visual consequences. More recent research in our field has also found that if we follow these kids into early grade school, we see associations with early literacy and reading problems. And yes, while learning is multifaceted and complicated, vision plays a large and important role. When these children that have a higher farsighted prescription are learning to read, they often have to work a lot harder to clear things up on the page compared to their peers that have lesser prescriptions. And this can be really difficult for some of those farsighted kids. If children have a hard time clearing things up that they're reading on the page, learning to read is also going to be very difficult, and that can snowball into worse problems as they enter through more advanced stages of reading and learning. The research that I am currently working on is to see if we can help those babies who are born with higher amounts of farsightedness and who are at risk for developing these visual problems with early intervention. Specifically, I am looking to see if early refractive correction, or wearing glasses, can help these babies reach more normal amounts of farsightedness early in infancy, or enhance that emmetropization process in the babies who are not at risk of undergoing it. I am conducting a clinical trial that is randomizing highly farsighted 3-month-old infants to early glasses correction or observation only, which is currently the standard of care. I have been working with pediatricians in the Columbus, Ohio area to screen infants for high amounts of farsightedness at their 2-month well visit. If parents are interested, I dilate the child's eyes and check their child's prescription. If their child has a high enough farsighted prescription, parents are offered the opportunity to enroll them in a clinical trial. The infants in the study are followed for 15 months while monitoring their prescription, their visual acuity, eye focusing, eye teaming, and eye health. Results from this clinical trial will provide important information in many aspects. First, we will have a better understanding of the emmetropization process in humans and the mechanisms that are at play. If we find that emmetropization can be enhanced in highly farsighted babies, the risk of developing things like lazy eye or an eye turn will also be reduced. We might also find that the visual burden that many of these children have in early childhood may be reduced or eliminated, and eliminate the visual roadblocks that may have made reading and early literacy much more difficult. The lifelong need for glasses, contact lenses, or refractive surgery for high farsightedness would also be reduced, if not eliminated. Positive results might make infant eye examinations or earlier vision screenings more commonplace. And most importantly, positive results might provide a new therapeutic option for clinicians, and more specifically, provide better prescribing patterns for highly farsighted infants, as right now there is no gold standard in our field. Perhaps several months of glasses wear in infancy may prevent a future of vision problems or glasses wear in the future.